So this begs us a question of defining a few terms. So we've recognized that palliative care is the treatment of physical and spiritual and social and psychological and therapeutic symptoms. What does it mean to do primary palliative care? Primary palliative care refers to the basic knowledge and skills that all professional practitioners should have in the relief of suffering. This, at minimum, should include the relief of pain and other key symptoms at the end of life. Key communication skills, obviously, to identify goals of care that are most important to a patient, to give them a preferential death, to be able to meet them where they want to be in terms of their therapeutic interventions at the end of life, and then to do so in a morally and ethically responsible manner. This is primary palliative care, and I like to compare primary palliative care to primary orthopedics. If one of you was to see a patient in the emergency department who broke their ankle, you would perform an x-ray, you would perhaps have to reduce that ankle, you would put it in a splint, you'd give some pain medication, and you would arrange for that patient to see an orthopedic surgeon at some period of time later. That is primary orthopedics. If I was to take that patient to the operating room and put pins and plates in their ankle to repair their fracture using ORIF techniques, that would be tertiary orthopedics. So that's the subspecialty of orthopedic surgery. Primary orthopedics, any of us could identify an ankle fracture and put it in the appropriate splint. That would be primary orthopedics. It's the same comparison for primary palliative care. Any of us could see a patient with malignant pain that is related to tumor burden, be able to recognize that there is no other etiology for this particular patient's pain other than their tumor burden, exclude other causes, and then treat them appropriately with higher dose opioid medication and adjuvant medications such that they would be comfortable and that their primary tumor pain has been addressed. That would be primary palliative care. In the United States, tertiary palliative care is the subspecialty board of hospice and palliative medicine. So if you are one of 8 or 9 different specialties, including emergency medicine, you can go for advanced fellowship training after residency training in the subspecialty board, hospice and palliative medicine, HPM. And it is a specific training practice pathway that recognizes the unique clinical research and service models of, in this case, emergency palliative care practice. So certainly palliative care physicians practice generally in hospitals and generally in a consult service format for subspecialty providers of all different sorts taking care of terminally ill patients that have some primary problem in their subspecialty. So emergency palliative care begins to identify those patients who present to emergency departments who will primarily benefit from pain and symptom management related to their terminal illness. And we really believe in the relief of suffering for this subgroup of patients, and to do so through validated interventions that have been tested in a research program. The EPIC-EM grant timeline, we had a 4-year grant, and we had 4 very big goals for our grant. In the first year, we wanted to define a body of knowledge. There certainly existed a body of knowledge within those who subspecialize in hospice and palliative medicine. The EPIC project had existed already, but we wanted to take that information and contextualize it to the emergency department so that we could say, well, within the confines of this specific care area in our hospital, what are the key areas that need to be met in terms of cognitive domains for palliative care. That was year 1, to find the body of knowledge. Year 2 was to disseminate that knowledge, and we did so through the creation of a 2-day train the trainer certification course. We had a goal to have a trained provider in each emergency medicine residency program in the country, which was a big goal to meet, and one that took many years of training to be able to attain. But that one person could go back and take all of our course materials slide decks, a 400-page textbook. We developed videos with patients and providers role-playing complicated end-of-life dilemmas and allow those to be used to trigger discussion in small groups. All of those materials were brought back to their individual residency programs in this train the trainer format so they could disseminate that information to all of their learners. In year 3, we meant to move from education to research and begin creating symptom assessment tools. And then in year 4, testing those symptom assessment tools paired with important interventions. And I want to take you through sort of some of the outcomes of all 4 years of this grant to kind of give you a flavor of the work that we had been doing during the grant and what we've done since. So these are the core palliative care domains for emergency medicine that we identified, and I'll show it to you in a different slide here as we begin the 4th segment of our talk, the domains of emergency palliative care. We identified 14 topics that we feel all emergency physicians should understand from the perspective of primary palliative care. And not to read all of them to you, but they can certainly be grouped into categories. You know, when you think about death trajectories and symptom assessments, goals of care, understanding advanced directives, much of that is recognizing the personal preferences of patients, identifying them on a death trajectory, how close are they to death, making sure that based upon how much estimated time they still have to live, we can then match interventions that authentically respect their personal preferences for their own goals and create a system that allows that. We have several topics that are related to communication skills, including how you communicate with family members when you're going to withdraw or withhold life-sustaining interventions that aren't curative. How would you interact with patients and families who want to witness the resuscitation of their loved ones? You can imagine a patient comes in as a cardiac arrest and is getting CPR and is being intubated, and all of the lines and the medications and all the staff trying to resuscitate that patient, and then the wife walks in and watches the chaos. Is that good? Is that bad? There's certainly a huge body of literature to suggest that she may have better closure and understanding that everything possible was done for her husband if she witnesses that resuscitation. But how do you interact with her? What do you say? Who's responsible for her so that it's done, this witnessing of the resuscitation is done in an ethical manner? How do you disclose death to surviving family members and next of kin? The last several topics here you'll see are mostly symptom management topics related either to complications of pain or other symptoms, specific lectures on the complications of cancer, and then a specific set of lectures around the last hours of life. What do you do to address terminal dyspnea, terminal delirium? How do you extubate a patient in a way that doesn't let body fluids fly everywhere, that doesn't cause them to gag or cough in ways that the family members may interpret suffering? What medications do you give to do it in a skillful manner? Those are the sorts of topics that we wanted to get across to all emergency providers. As I said, in year 2, we disseminated this material using the Epic EM Trainer course, a 2-day course. It's got a 400-page course manual, and if you're interested, I won't belabor the course, but you certainly can look it up online at epic.net and learn more about this course and the perhaps 20 others that are related to the original Epic course. In years 3 and 4, we wanted to do symptom assessments and test interventions. And one of the symptom assessments that we created was the SPEED tool. This has been published in the Journal of Palliative Medicine. And this is sort of a nice, simple tool that I thought I'd share with you all as an example of some of our work and maybe something that you might want to use in your own practice there. It's the screen for palliative and end-of-life needs in the emergency department. It's a validated tool. It's only 5 questions, one for each of the 5 domains identified in the World Health Organization definition and the EPIC-EM definition of palliative care. And this is a screenshot of a triage computer screen, and you walk into a triage booth in our emergency department, and a number of questions are asked about you. And one of the questions that has to be answered, I don't expect you can see the screen, but I'll read it to you, is the active cancer screen. Yes, no. Are your symptoms related to a previous diagnosis of cancer, or in the last 12 months have you undergone any cancer therapy at all? If you answered yes to that, then another screen would pop up on the computer, and the nurse would ask these 5 questions on a 10-point Likert scale. And these are the questions. How much suffering is occurring? How much are you suffering from pain? How much difficulty are you having getting your care needs met at home? How much difficulty are you having with your medications? How much are you suffering from feeling overwhelmed? And how much difficulty are you having getting the medical care that fits with your own goals? And unfortunately, the boxes seem a little bit off on this particular computer I'm using, but each question has a threshold value. And at threshold, we were able to recognize that if you score, for instance, this is the question, how much are you suffering from pain? If you score 4 or above, you have unmet palliative care needs that can be predictive of a number of things. Rehospitalization, if the pain is not managed in an appropriate manner, and death. This tool predicts death in patients. So we asked these questions of every single patient with cancer who presented to the emergency department, simply to see, are we addressing all of their palliative care needs? So for instance, in a several-month period at Northwestern, 828 cancer patients came to the emergency department, 43% of which had a pain score of 4 or higher. They were having unmet pain management needs. Very similarly, at Emory University Hospital in Atlanta, 1,000 cancer patients in a particular time period came to the emergency department for whatever reason, and quite similarly, 40% met threshold. And if I look at all 5 of the speed questions, there's striking similarity between the unmet palliative care needs of cancer patients at both Chicago and Atlanta-based hospitals. And I think this is a very nice, quick, easy tool. So suffering from pain, unmet care needs at home, difficulty with medications, are you overwhelmed, and do you have care that meets your goals of care or not, with specific threshold numbers. If you're screening positive to any of these questions, then you have unmet palliative care needs, and we need to intervene. We have to provide therapeutic interventions to improve your quality of life. So what would those look like? We had a flow chart that allowed us to unfold a number of different therapeutic interventions. So you see a patient presents to the emergency department, they're screened for cancer, because this was a National Cancer Institute sponsored grant, but you could screen for any terminal illness. And then you ask the 5 speed questions with threshold values that are listed there. If they're above threshold, then you follow the column down, and it unpacks a number of different interventions that could be rolled out in the emergency department. So for instance, if you had unmet pain needs, you would have a secondary pain assessment done by a nurse, a very thorough set of questions trying to understand exactly why your pain is not being managed. Do you take medications that are inappropriate? Have those medications stopped working for you? Are you confused about your medications? Can you not afford them, etc.? And then questions about the type of pain. Perhaps some terminally ill patients with certain types of pain will have pain that's not responsive to opioids, yet they have prescriptions for opioids. Then the physician gets a pain protocol prompted on their computer screen that they can click through, and a number of interventions can occur. And then importantly, our boarded subspecialists in palliative care, our tertiary palliative care experts would be consulted. Picking one other column, if you feel overwhelmed by your terminal illness, A mental health assessment is done by our nurse. There's bedside counseling done by a social worker who's been formally consulted, as well as a chaplain who comes and talks to you about your spiritual needs, and ultimately a palliative care consult would occur. So just to show some of the screenshots, the secondary pain assessment, like I said, is quite extensive and includes a number of factors about the pain, trying to understand the qualifications of the pain and its ability to be treated by opioids or not. There's a pain order set that would pop up in our computers where you could click through a whole host of different options, many of which would be populated with checkboxes based upon the answers provided to the nurse in the secondary pain assessment. And just looking at sort of the overall burden to the system, when we start asking these questions and start doing these interventions, we start consulting many more of our colleagues. And the question is, how much more work would they do? And at least at Northwestern, on an average week, we assume that 12 more social work consults would have to happen, 16 palliative care consults, and just about 8 chaplain consults. So do we have enough staff members in our hospital to be able to do this, or can we plan ahead so that these folks can be in the emergency department, identifying these patients in short periods of time and being able to intervene for what they need?